So I'm speaking to you from Kuching. I gathered you can see me, but I cannot see any one of you. Okay, so that's my first slide. Thank you so much, Sumin, and good afternoon, ladies and gentlemen. It's really a big honor for me to talk to you all, especially on a Saturday afternoon, and especially speaking before Dato Jara Menon, who was until recently the national head of internal medicine and gastroenterology in the Ministry of Health in Malaysia. And somehow we didn't plan this together actually, but somehow we also graduated together from University of Malaya in 1981. I have a passion for medical education, and that's why I'm still doing part-time in the government hospitals as well as at the local university. So I go straight to my lecture. This is a sponsored talk, like many of the CME talks in the world. So the sponsor is responsible for distributing Urif or Silodosin. So at some stage, I have to talk about this product. Many of the CMEs now I see nowadays are loaded with drugs, studies, guidelines, specialist knowledge, which is all important to that particular specialty. Today, I'm talking to pharmacists, to doctors, to general doctors who are non-neurologists. So I think it's more important for me to share with you some useful tips for your practice. And personally for me, since 1987, I've been a full-time neurologist. 1/3 of my workload is actually in this region of LUTS or lower urinary tract symptoms. So I'm going to share my feelings about management, but I hope that I can learn from you as well. There'll be time at the end for Q&A, and there's even an MCQ at the end where there are attractive prices if you can answer correctly. So what is the objective of this lecture? As I said earlier, I will tell you what is new in LUTS and BPH and what is important for your practice. It is a big chunk of the urology practice. And I think you look carefully at your practice, I think it can be quite important. Then to tackle this topic conceptually, I think the public and many doctors think that the prostate size is paramount. So they must take a medication to shrink the prostate. And since prostate conditions are so common, who are the ones we need to treat? Who are the ones that we must give medication or do operation? Otherwise, they can go into kidney failure. And then next step is investigations. I think most people nowadays, doctors, patients, they are interested in doing all kinds of testing. So generally speaking, I think the dipstick and ultrasound is good enough. So we can discuss it. And then medications. There are so many medications that we can use. New medications, old medications. Why are still people using the very, very old medications? And which are the new medications which are not so expensive? And I share with you my preferred practice. And then we mustn't forget, non-medications are important for any medical condition. Lifestyle changes, dietary changes, supplements, and of course, in this condition, the care of the bladder. And finally, a word about Nocturia, which is the commonest lower urinary tract symptom. Now, what is the prostate gland? The prostate gland is a sex organ. It produces 90% of the semen. It is important for ejaculation. It is usually important for erection in men. Okay, so if you have any problem with the prostate gland, you may have problems with erection. The other important gland which people forget is the bladder. The bladder stores the urine, and the bladder muscle is responsible for passing out the urine, for voiding. Okay, and then of course this is controlled by the sphincter. But the sphincter, and nearby, of course, we have the penis, we have the testes, and of course, the organ that produces the urine is the kidneys. So these are the anatomical structures important for the generation of LUTS. What actually causes LUTS? You must have correct diagnosis, right? Otherwise, you cannot give the correct treatment for the patient. So everybody think about the prostate, so which I will elaborate for the rest of my lecture. Then people forget about the bladder. The bladder can have infection. Everybody knows about that. And now people are getting to know about OAB, overactive bladder. The bladder is, as one gynecologist referred one case to me recently, hypersensitive. But there's another big group of patients which bladder are underactive. They are not working. They have gone to sleep. Then we have the urethra, urethral sphincter dysynergia, urethritis, urethral strictures, sphincter dysynergia, and urinary tract symptoms can be caused by organs nearby. So you have a stone in the ureter, you have a cervical cancer, you have a cancer in the anal rectum. All this can cause urinary symptoms. You can have a patient with diabetes, producing a lot of urine, they also got frequency. And of course, all this is controlled by the nerve, the pelvic nerves, the spinal nerve, the nerve to the brain, and of course, all this is controlled by the hormones. Okay, so there are many factors which can cause a lower urinary tract symptom. So if you're going to prescribe medication, you're going to give medication to the patient, make sure that you have the correct diagnosis. Okay, correct diagnosis. That is important. So now we zoom into BPH. What is BPH? BPH is benign prostatic hyperplasia. It is an enlargement of the prostate caused by an overgrowth of prostatic tissue. It can lead to interference in urination. It can, but it may not. It may not lead to difficulty in urination. So this is the prostate that is enlarged, and it causes a compression, and therefore the patient has difficulty passing urine. Difficulty passing urine. But if the prostate doesn't enlarge onto the prostatic urethra, the prostate can be very big, can be 100 grams, but the patient can still pass urine very well. So patients like to go for health checkup. So the radiologist will report prostate enlarged. Then they got excited. Oh, they must go and take a medication to shrink the prostate gland. So remember that an enlarged prostate may not cause symptoms. We don't have to treat every enlarged prostate gland with medication or whatever. There are other factors: urine flow, bladder, the nerve, etc. But having said that, as we grow older, okay, I'm 66, so I'm here. So there's a 60% chance that I have microscopic evidence of BPH. So microscopic BPH is extremely common. Therefore, they will usually translate into very common in your clinical practice. Nowadays, I see about, well, I think my practice has remained very stable over the last 20 years, about 15 patients per day. And 1/3 of them will be LUTS. So it's a very common condition that brings the patient to see a doctor. And I'm sure it's also in your practice. It's a matter of whether you pick it up or whether the patient thinks it's important or whether you think it's important or not. So it is a very prevalent condition. So how do one diagnose lower urinary tract symptoms? Okay, so first is the group of symptoms which are obstructive. In other words, the patient have difficulty passing urine. So they have poor stream, they have voiding problems, they have to strain the pass urine, they have hesitancy, they have intermittent stream, they have incomplete emptying, and they have dribbling. So if you give a patient a medication for the prostate, make sure that he has one of these symptoms. Okay, make sure you have one of these symptoms. What about the other group of symptoms? The other group of symptoms are so-called irritative symptoms. The patients have urinary frequency. Nighttime, they have nocturia. When they have urine, they must run to the toilet. And if they don't reach the toilet in time, they have incontinence. These symptoms may be due to enlarged prostate, but may also be due to the bladder. Now, if a patient has got prostatic enlargement, he should have no pain in passing urine. Okay, pain means inflammation. He should have no blood in the urine. If you have blood in the urine, you may think of something else, tumor, for example. So this picture is a picture of my daughter. Okay, when she was a medical student in 2015, she gave a poster presentation, and she taught me the mnemonics that she used for diagnosing. The father is a urologist, so they must know about urinary, how to remember all the urinary symptoms. So the obstructive symptoms, you can remember it by PhD, poor stream, hesitancy, terminal dribbling, and the other group of symptoms are called funny: frequency, urgency, nocturia, incontinence. So by learning these two mnemonics, you can more or less diagnose which group of symptoms the patient is suffering from. And remember that the women don't have a prostate, but they can also have these symptoms. So LUTS is not equivalent to an enlarged prostate. So hopefully this will help you in your diagnosis when you prescribe or give medicine or dispense medicine to patients. They must have no dysuria, no hematuria. If they have that, think of something else. Another thing is the use of questionnaires, validated questionnaires. There are validated questionnaires in life for everything, okay, including for the urinary tract. So I find this a very important tool to use for my patients. You can put these leaflets in your clinic or in your pharmacy, and the patient can look at those symptoms and they can tally it up. So I use it for every patient of mine that has got LUTS. It's a good document. It shows that you are interested in the patient, and not just giving them a medicine for whatever they complain. One very important question is the problem of quality in life. So a lot of Asian patients, especially patients from the rural areas, they have a very high symptom score. You ask them, how is your urination? Oh, my urine flow is very slow most of the time. So they got a 5. But they are not unhappy. Just like me, I drive my car very slowly. I can still reach my house. Nobody complains except for my wife. I said, where have you been? You stop somewhere else. No. So remember that the symptom score is important, but what is more important is the quality of life score. So if the patient has got no complaints from the symptoms, they may not deserve the treatment that you are thinking for them. Okay, now let's go through each symptom in a little bit more detail. The most important symptom is nocturia. This is the commonest symptom that a person will come to see you with. And nocturia is defined as passing urine one time a night after going to sleep and going back to sleep. Okay, so most people will have nocturia once or twice, or even up to 3 times. But the most important thing is, does it affect the sleep? If the patient passes urine 3 times a night, he wakes up, he passes urine, he goes back to sleep, and he sleeps well, then it may not be grounds for treatment. Women also have a lot of nocturia, but it's not due to the prostate gland. Long time ago, when I was working in GH care, a lot of patients get referred to me for prostate surgery because the patient complained of nocturia. So that was the wrong treatment at the time. The other important thing is the question of polyuria. So if you pass urine a lot at night and in the daytime, that means you've got a global polyuria. And of course, in Malaysia, the commonest cause of that is diabetes. So make sure we're not treating a newly diabetic patient with medication for the prostate gland. So that is another important point. Next, of course, we have to examine the patient. We have to examine the patient. I know the pharmacists cannot really examine the private organ. In fact, many doctors also will not examine. So first of all, if the patient complains that he got problem with urination, you at least have to inspect the penis. Like for example, this man has got a very bad phimosis, bad diabetes. That was me examining a patient 20 years ago. Nowadays, we can't examine a patient with bare hands. You have to wear a pair of gloves. So you must examine the patient. And if you're not going to refer the patient to another doctor like a urologist or a surgeon or the general hospital, you have to do a rectal examination to make sure that you don't mix up gross rectal findings like cancer prostate, cancer rectum, lax anal tone, or constipation. So you have to examine the patient if you're not referring the patient, at least during the first visit. So a DRE or digital rectal examination is very important. And then you do basic investigations. The dipstick. If the dipstick, you expect it to be normal. Normal. Of course, every patient that sees you for the first time, you must take the vital signs. Vital signs. Okay, the blood pressure, the heart rate, and of course, and the body weight. Obesity is also one of the risk factors for all kinds of diseases. And most patients, if they come for urinary concern, they would have done a PSA. And then the PSA or the prostate specific antigen is above 1.5. It's likely that the prostate is above 40 grams, and therefore they will definitely need the medication to shrink the prostate gland. In a normal patient with low tract symptoms, with no urinary abnormalities, there is no ground for cystoscopy. So if you send the patient to a urologist, and the next thing he has done is the cystoscopy, then there's some over-servicing. So this is, to me, this is the baseline, basic one. The other basic investigation is the ultrasound. I think most surgeons, almost all urologists, and many of the GPs have an ultrasound in the clinic. So the ultrasound is very useful extension of your physical examination. You look at the kidney, look for hydronephrosis. You can measure the size of the prostate gland by measuring the 3 dimensions. And of course, if there's a stone, there's no point giving the patient medications for the prostate. You will have to refer the patient to a surgeon to clear the stones. Okay, and also you can look at the anatomy of the prostate gland. If the anatomy is protruding into the prostate, what they call intraprostatic protrusion, then these patients are less likely to benefit from medical treatment. If the patient has hydronephrosis, they are less likely to benefit from medical treatment. And of course, if the prostate is not enlarged, don't give a medication to shrink the prostate gland. You're giving the patient the wrong medication. So the standard of care for urological imaging is usually an ultrasound of the urinary tract. In Malaysia and in many developing countries, especially in the government sector, we also do an X-ray because stones are so common. If there's any suspicion of stones or tumor stones, we do a low-dose CT urography. If we suspect any tumor, we do a contrast-enhanced CT scan. Usually, we don't like to do CT scans in children and in young females. In fact, the CT scans that have been done by urologists have really decreased because we now know the dangers of routine CT scans to look for urological pathology. The next important test, in my opinion, not all urologists agree with me, is that of a uroflowmetry. Okay, you send the patient to the urologist or to the uroflow clinic or the gynae clinic. They have a uroflow meter there in the toilet. So they pee into the machine and the machine will come out with a reading. It's very much like the checking the blood pressure or doing an ECG. Imagine that you give the patient blood pressure medication for years and years, and you actually never measure the patient's blood pressure. It's the same like that. So this is a normal uroflowmetry. This is showing the uroflow is low and there's prolonged voiding. So uroflowmetry is extremely important. This is an obstructed uroflow. We give the patient medication or we give the patient surgical treatment and the flow improves. So uroflowmetry is available in all the urology clinics. In the UK, it's available as a walk-in service. Just like you send the patient for ECG, the physician or cardiologist don't have to see the patient. Okay, now we talk about in broad view about the drugs. So patients want a medication to shrink the prostate gland. So the idea is the prostate is enlarged, causing obstruction. You give a medication, the prostate shrinks, the prostate gland opens up, and the patient can pass urine well. And luckily for urologists, there are only two medications to shrink the prostate gland. Okay, finasteride, which has been around since 1991, is freely available as a generic. Dutasteride, I think soon going to be available as a generic. So these are the two drugs. You have to take the drugs for 6 months to show an effect, and you have to maintain it. You have to maintain it. No point giving the patient a medication for 1 week or 1 month and expect a result. Okay, of course they can have a result, but sometimes it's placebo result. Now the problem with giving medications to the patient is that the patient can go to the internet and just type in the name of the drug. Avodat. What are the side effects? And all the side effects that is reported by the patients will be there. So for example, if you type in dutasteride, they will say the patient can have irreversible ED, the patient can have high-grade carcinoma, and recently I think they added one more, possibility of suicide, whatever, you know. So many of these drugs do have side effects. And so you have to justify the reasons to give the medication. And some of the side effects are common sense side effects like nasal stuffiness, giddiness, allergy, but there are some serious side effects which may or may not be true, but you must be ready to know the side effects of the drugs and to be able to defend why you're giving the medication. Why are you giving a medication to my father? The doctor called me from Adelaide. Dr. Lay, why are you giving this medication to my father? I see on the internet, this medication is reported to associated with high-grade cancer prostate. So you must be able to answer the question. We can discuss that later on. So the medication takes 6 months to work. Therefore, it's better to give them a medication which relaxes the smooth muscles. And this works almost immediately. So most of the doctors or the urologists will give the patient a medication to relax the prostate gland. They get immediately relief. But if the patient studies the medication, oh, this medication is used also for hypertension. It doesn't shrink the prostate. I don't want this medication. So you must know the pros and cons of each medication. So the first medication I mentioned, they belong to the group of 5 alpha reductase inhibitors, the dutasteride and the finasteride. They reduce the prostate volume, improve the symptom score, but it takes long time, takes 6 months to work. But if the prostate is reduced, it will reverse the natural history of the condition. In other words, there is a chance that the patient do not require surgery, will not go into urinary retention. So for long-term treatment, you need to give them a 5 alpha reductase inhibitor. Short-term treatment, you can give them an alpha blocker. It works almost instantly. So the pharmaceutical industry said, we have this magic drug. Why don't we put it together? Do or that. Okay. So any patient comes with urinary symptoms, we just give them do or that. Okay. But of course, it is not cheap, it's expensive. So that is actually, to me, not the solution. You must find out what is wrong with the patient, the size of the prostate, and give them the correct medication. So now I go through some cases with you. Okay, I have been looking for a long time. I share some cases with you which have a teaching point. I think that's more important than giving you pharmacological data. So my index case is a man who is 60 years old. His main complaint is slow urination. Actually, not his complaint. It's the wife who complained that he's in the toilet for a long time. I don't know what he's doing there. Maybe he bring his phone inside there and look at all the messages from his ex-girlfriends, and they go for holiday. The tour bus has left already and he's still inside the toilet. Or sometimes some of the housewife will complain, the toilet is always dirty because his urine flow dribbles into the floor. So what medication would you give the patient? Think for a while, and then I will share my answer with you. These are the possibilities you can give after having listened to the first part of my lecture. So you can give them an alpha blocker. Alpha blocker traditionally they're used for hypertension. Like prazosin was the first one that was used. You can give them prazosin, but you give them prazosin high dose, many of these patients will faint. So you give them half a milligram and give them at night. Or you can give them a newer one, tarajosin. It's supposed to be uroselective, 2 milligrams. We have 1 milligram, 2 milligram, 5 milligrams. America have 10 milligrams. Or why don't I save money? Save money. I give them full dose alpha-josin, but I cut the tablet into 2, or the patient will cut the tablet into 2. Okay, so they give them an alpha blocker, and I give them for 1 week, and then 1 week's time they come back again. I increase the dosage if it's not enough to 5 milligram or 4 milligram or 1 milligram, depending on what you give them. In the private practice, it's probably feasible, but if you're a public health medical officer, then the patient will come back in 3 months' time. So they'll be taking. I've seen patients taking prazosin half milligram for 3 months until the next visit. The second option is to give them a uroselective alpha blocker. What do you mean by uroselective? In other words, it doesn't act so much on the cardiovascular system. There's less risk of hypotension, and I can give them full dosage instead of titrating it. So we give them a newer uroselective alpha blocker like silodosin. Give them 4 milligrams and ask them to take it at night. Or I heard about this magic drug, duodat. Yes, duotherapy. You string the prostate, relax the prostate. Just give them duodat. Or no, patients nowadays, how can I give the medicine? Do some tests first. Let's do blood profile, do urine profile, do the PSA, and maybe the patient said, you haven't scanned me. Why don't you do a scan? Send the patient for ultrasound. Send the patient ultrasound or urine check first. So these are the possibilities of how you can handle the patient. Okay, let me share with you my views of each option. So alpha blockers, I won't choose alpha blocker or a non-uroselective alpha blocker because it takes time for it to work. Okay, you need to titrate it upwards, and even then, there's still a significant risk of postural hypotension. So, in my choice, in my hands, I choose a uroselective alpha blocker, and of course, for today, it will be silodosin 4 milligrams at night. Okay, I prefer it because it will work immediately. The chance of drop in blood pressure is less. And of course, in the public hospital, you may have no choice because not all the newer drugs are available. But you can offer that to the patient. Doesn't mean that the patient go to public hospital, they cannot buy the medication from the local pharmacy. They can. The idea of dividing a formulation which is XR or MR, in my view, I think is wrong because the formulation is meant for slow release. So if you cut it, then it behave differently. Just like you're going to McDonald's and buy a hamburger, and then you cut into 2 to share with your wife, so you still save some money, but actually all the juice will come out already. So it's not good to cut medications which cannot be divided into 2. And I've seen pharmacists who actually label the medication. Do not cut the medication. So I hope all the pharmacists listening are giving the patient that kind of advice. Duotherapy, to me again, no, because you need to know whether the prostate is enlarged or not before you give them the drug to shrink the prostate gland. And of course, there's a cost element, Do baseline tests. You can do the dipstick in the clinic. You can do a blood test, finger prick for glucose in the clinic. And if there's a family history, if there's any indication, anything you worry about cancer, then you can do a tumor marker like PSA, prostate-specific antigen. And ultrasound, if you have the ultrasound, you can do it. Otherwise, you can send to the radiologist, actually not the radiologist. Most hospitals now use a sonographer. And remember that the patient will tell you, I have been to this top medical center. They have done the ultrasound, nothing, no stones. And then when the patient lies down, you scan the bladder. There's a huge bladder stone. Why? Because most hospitals, when they do health screening, they do not scan the bladder and the prostate. They only just scan the upper tract. They scan the abdomen because it takes time for the radiologist to feel the bladder when they ask the patient to drink water. So be careful what was scanned and what was scanned. Okay, another case. So this patient, has got retention, and they go to a hospital or go to a clinic, and the doctor put the patient on a catheter and send the patient to the clinic to have the catheter changed every 2 weeks. Unfortunately, I find that it's still the SOP for many of the government clinics. The poor patient will go to a clinic kesihatan, and the instruction is to change the catheter every 2 weeks, and no doctor ever look at the patient anymore. No doctor. They can be changing catheter for months and months. So he got fed up. So he went to see his, he was given tetrodotoxin 1 milligram. Okay, there's under dosage, and given 90 tablets. In other words, he's going to take this for 3 months. Okay, 3 months. Unfortunately, that is, to me, it's not such a good center. Okay, lah. Okay, not such a good center. Of course, there's no worry lah, because his blood pressure is quite high, 179/91. So he went his family GP. The family GP said, "Oh, terazosin is a blood pressure medicine. So maybe they didn't give you any medication at all for your prostate. Right? Let me see. Okay, prostate enlargement. Give finasteride." So he give this poor patient finasteride. Of course, we know finasteride also takes 6 months to work. So again, he still cannot pass urine. So he has not. This patient has got retention and he has not been given an effective medication or even a plan of management to get him to pass urine. Okay, so this is another case. This is a very recent case, 23rd October. This is another patient. So we move to another group of patients. These patients, they have troublesome frequency. When they go for meeting, like today, our meeting is quite long, right? So he has to stop the meeting somewhere, or if he's driving a car, he has to stop the car and pass urine in the behind the bush. But of course, if you're female, even worse. And some people in KL, they have to keep plastic bags in the car. And if you're a high court judge, you know, the lawyers are so long-winded. I understand there's another session going on about medical legal matters for doctors. So if you go for long meetings, then some of them actually wear urinary diapers. So the problem is urinary frequency. And if you don't reach the toilet in time, you may even leak urine. You have to stop at the car park. And no, this is, you have to wear dark pants. This actually is a picture of myself. Nowadays, you cannot simply take pictures from the internet and share with everybody, because somebody will write you a love note to ask you for money. So they have to modify the lifestyle to tackle the urinary symptom. And the symptom, according to another patient, this is a very recent patient, okay, born in 1952. So the wife said, this patient, he got frequency, he got incontinence, I have to give him wearing pampers. And then what's the treatment given by the doctor's concern? The doctor's concern put urinary symptoms. Okay, urinary symptoms in a man, must be the prostate, BPH. Oh, I know already, this drug can treat everything. So give him Duoda. Okay, give him Duoda. Dr. Lei said, must take 6 months away to work. Give him Duoda 6 months. Still no better. Then he said, let me do a rectal examination. Rectal examination, prostate not that big leh. How? So send to me, please advise. Okay, so this is another patient. Okay, the overlying symptom is urinary frequency, urgency, urge incontinence, nocturia. Okay, so this is the other group of patients. And this is another patient. So nowadays we have apparently too many doctors, okay? But actually I can tell you, when they are in the government clinic, they still see 50 patients a day. So this patient went to the government clinic, vital signs taken, a focus urinary symptoms taken, LUTS, for 1 year. They did the symptom score. What are the symptoms? Incomplete emptying, weak stream, 0. He never said he got weak stream. His problem is frequency, urgency, nocturia 4 times. Okay, quality of life, not so bad. Check the blood sugar. As if blood sugar alone not enough, many doctors in the world nowadays automatically do a HbA1c. Okay, insurance company won't pay, 5.8. So BR prostate enlarged. So I don't know what is in the mind of this doctor, but unfortunately, he has to discuss with somebody. They're very dangerous. I discussed with my wife. I discussed with somebody. And who is this FMS? I think family medical specialist, something like that. So unfortunately, this was discussed. And what is the medication? What's the outcome? Terazosin 1 milligram daily. So nothing for the enlarged prostate, nothing for the frequency. Okay, so that is a problem. So the diagnosis, I'm sure by now, most of the audience listening to me will know that this patient did not have an enlarged prostate causing obstruction. What he has is the other group of symptoms, the storage symptoms, the bladder symptoms, an overactive bladder. Okay, so that is the second case scenario. Now this is the third case scenario. 74-year-old plumber. Concern is leg swelling, nocturia. Okay, so he go and see this GP in KK can be anything KK. And the GP said, oh, leg swelling, knee jerk, give diuretic, basics. I look kacang, get antibiotic. But of course, he didn't get better. He still got the nocturia. So now say, oh, the government clinic, very good, free of charge. I pay $1 only. Oh, I'm 74, no need to pay. Najib said, don't have to pay. So this government doctor said, oh, nocturia, I must be the prostate. Let me give him alpha blocker, give him mini-press 1 milligram BD, still no better. So he came back to Sarawak to Merida to see a senior physician, his OGP last time. So he ran a blood profile, and to cut the long story short, he has got extremely high PSA, non-high PSA, alkaline phosphorus also very high. Alkaline phosphorus, as you know, is the liver and the bone, and his creatinine is 184. So cut long story short, he has prostate cancer, compressing of the lymph nodes, compressing of the ureter, hydronephrosis. So it's a completely wrong diagnosis. Okay, so this is another case scenario. Another patient that I saw when I do my traveling clinics, he is younger than me, 64 years old. He has been taking this magic duo therapy for 5 years. And this doctor has access to the Euroflow clinic, so he has done 10 Euroflows, and there's no improvement. So finally, they say, okay, maybe you can see this senior, even more senior urologist. And I take a history from him. I said, well, probably not the prostate, not the bladder, because you have a slow flow. So I said, did anybody disturb your urethra? No. He said, no, I never fall down. But yes. Some years ago, I went to the hospital, and the orthopedic surgeon decided to do a total knee replacement for me. Very high risk of getting a total knee replacement if you see orthopedic surgeon. And I said, knee surgery got nothing to do with your penis, ma? Oh, no. When I went for the surgery, somebody came to me and poked something into my penis. And when I wake up, there was a lot of blood around my penis. So basically, he had an iatrogenic induced stricture of the urethra, which you can easily diagnose by doing a retrograde urethrogram with your friendly radiologist. So this, of course, this treatment is completely different. Okay, now I'll give you another fourth scenario. 70-year-old man, the wife complained. This old man has turned senile already. Every night he wet the bed. But you talk to him, he's perfectly sane. He talks senile. He's very sane. He can remember everything, but every night the bed is wet. Okay, and this is a new symptom, 3 months. Okay, and I lie him down, examine him. He got distended bladder. I put the ultrasound probe on his abdomen. He got hydronephrosis, and I asked him to pee and come back. He still got the distended bladder. The bladder is thickened, and the prostate is enlarged. Okay, look at this very carefully. Look at this very, very carefully. Okay, next slide. So there's only one diagnosis. Only one diagnosis for a man with recent onset enuresis, high pressure chronic retention. Okay, you touch the bladder, it's very slightly tender. It's not acute retention. They have been having this for a few months. They got biliary hydronephrosis. They slightly high blood pressure, 160, 100. And you check the blood, they got serum creatinine. So in these patients, if you put the catheter, they will go into marked diuresis. You send them back, they go to the grab station, waiting for the grab, they will collect at the grab station, and they die at the grab station because they got postural hypotension from marked diuresis. So these patients should ideally be admitted. If they have no money to be admitted, then I make sure that they replace their losses by drinking electrolyte solution. And I usually, if they have no money to be admitted, I usually help them by keeping them in the clinic for the whole day because there's no charge for keeping a patient in the clinic. You monitor the blood pressure, you put a line, in case the BP is low, we can give them some IV fluid in the clinic itself. Because hospitalization is so expensive nowadays. Another case. So this is one of my star cases. Actually, I collected this slide when I was still in GH care. So this patient had recurrent urinary retention. So retention means the prostate enlargement, prostate obstruction, right? Correct. Oh yeah, correct. So he had circumcision done. Okay? Circumcision didn't contribute to the retention. Then he had a TRP done in a top hospital. There are so many top hospitals in the world nowadays. Top hospital TRP done by top urologists. Still cannot pee. Okay, maybe it's take time for you to learn how to pee. So if they put a suprapubic catheter, put it there for 3 months, still cannot pee. So in the end, they end up with me in the General Hospital Kuala Lumpur in those days. General Hospital Kuala Lumpur. They look at him. He already got peripheral neuropathy. He's a diabetic. He already got a sore in the big toe there. So basically what he had was an underactive bladder due to diabetes. Of course, it can be due to aging. It can be due to some neurology. So some of the urinary symptoms that we have may be non-urological. So don't just give everybody treatment as if they are for prostate enlargement or for overactive bladder. Okay, so even some urologists, they miss this. So to summarize, recurrent retention in this group of patients may be due to an underactive bladder. So the bladder has no contraction at all, nothing, no contraction. This is the urodynamic study. Low pressure, This is obstructed. The pressure is very high and they cannot pee. This is the normal urodynamics. So urodynamics, I think in Malaysia is also grossly underused. Even Euro 4 is grossly underused. So this underactive bladder is so-called new condition. A new condition, it may be due to, so you see a person with stroke, with spinal problem on a wheelchair, and then they have got diabetes. They are taking all kinds of medications for psychosomatic disorders, and patients who have got recurrent retention. So think of it as an underactive bladder. Okay, so the treatment is different. No point giving them a medication for the prostate gland. They will not improve. Worse still if there was side effect from the medication. Okay, so now I'm going to mention briefly about Nocturia. Nocturia. So a patient comes to see me with Nocturia. Okay, he says that every time I pee, I drink a cup of water to hydrate myself. And not only that, he sleeps with the aircon. Why he got the aircon? Because the wife insists on having the aircon. And not only the wife is not having the aircon, the wife, when they go traveling, will always call him at midnight and say, "You must FaceTime with me." Basically checking on the doing a video call to check on the husband. So if you have Nocturia and you don't sleep well by whatever reason, by the garbage truck coming, including the garbage truck will come at 4:30 in the morning, or the dog's barking, or the birds waking you up at 5:30. So all these are problems with sleep, problems with Nocturia. It's a whole different group of patients. Okay, now I'm going to go through you very briefly. Briefly the pharmacology, the evidence for the drug who is sponsoring our talk today. So this drug is called silodosin. And my last review when I published, I have 134 patients. Most of them are using the drug for about 8 months. I use it only in one female patient because alpha blockers are so good for the lower ureter. So the stones will pass out. Okay, I did not use it much in children. Most of them are in older people. Older people. Don't say elderly, older people like myself. Most of them in older people like myself. And some of the young people who also have difficulty passing urine, they have got a sphincter problem. I also use some alpha blockers. So I have quite a good experience in using this product, silodosin. Okay, I use it mostly in new patients. I try not to change from a previous patient on some other alpha blocker like tamsulosin or Hanal unless they're not happy. Okay, sometimes some of the drugs, although they're in the same group, they can have a different side effect profile on different patients. Okay, so these are my patients. So this new drug called silodosin, actually not so new, has been around for a couple of years. It's very highly selective it's highly uroselective, very little postural hypotension, and it works almost immediately. So if you have a patient coming to the clinic in the morning when you open at 8 o'clock, patient have problem passing urine. You feel it is probably you can probably feel the bladder. You can give them a medication and ask them to come back by 4 o'clock if they haven't passed urine. Then you can put in the catheter. So it works within a matter of hours. And the patient I mentioned to you just now, they go to the hospital with retention, they put the catheter and they send back to the clinic to change catheter every 2 weeks without any medication. But if you give them a medication, give them an alpha blocker like silodosin or Urif, the chances of passing urine is so much better. Okay, 76% they can pass urine. So it doesn't mean that every patient with retention automatically goes to surgery. Now, you may think that alpha blockers are just like Panadol, they don't treat the underlying condition. But in actual fact, if you take an alpha blocker, especially silodosin, if you measure the voiding pressures, you measure the urodynamic parameters, they actually improve the parameters. In other words, there is a less chance of them having upper tract degeneration. Now, one very important word about postural or orthostatic hypotension. All the alpha blockers can give you hypotension, but they are less if they are uroselective. But you still have to warn the patient. Although it is very, very low, very, very low. Okay, but the older people, higher chance. And bear in mind, urinary symptoms are more in older people. So if say for example, I see a patient, he's 70 years old, I will be 70 very soon, and I give them the medication, I tell them, please take this at night, take this after dinner. So a lot of people, I don't know about in West Malaysia, but in Sarawak, they take the dinner at 5:30. So they take dinner at 5:30, they take your silodosin or take your alpha blocker, and they go to the supermarket and walk around, do window shopping. Then they can fall down. So I usually tell them, you take it at night before you go to sleep, and warn them about postural hypertension. Don't get up quickly, don't get up suddenly. You can fall down and fracture your skull. And many of these patients also have many other concerns. cardiac problem is a leading cause of mortality in elderly people. So this study proved that actually this drug has got no effect on the ECG, especially the QTC interval. So many drugs nowadays, if you use it for long term, it can affect the heart, and then they got myocarditis or whatever. This drug does not seem to have that effect. And it lowers the blood pressure only very, very slightly. We know that once you pass the age of 60, you may take some medication to improve your erectile function. And erectile function drugs can also bring the blood pressure down. This medication has very little interaction with sildenafil or tadalafil. It's safe to take both drugs before you go to sleep at night. Now, the discontinuation rate actually is quite low. The discontinuation rate is about 4%. What is the main problem? The main problem is that of so-called retrograde ejaculation. So after taking the medication, when they ejaculate, they find that nothing much comes out. Something do come out, but nothing much come out. The girlfriend can still get pregnant. So that is reported to be about 3.9%, although in clinical practice, I suspect it's a little bit more. But as many modern drugs nowadays, if you have a side effect, it means that the drug is working. So patients who do not have ejaculatory concerns after the medication, the drug don't work so well. So some of the modern drugs like chemotherapy, you don't have a skin rash, it means the drug is not working. So actually, what is this thing called retrograde ejaculation? If the patient has retrograde ejaculation, it means that the semen went into the bladder. So when you get up in the morning to pass urine, you should find sperm in the urine, right? No, not this case. They do not actually have retrograde ejaculation. It's not true retrograde ejaculation. It is just that they have less ejaculate. Now, whether it affects orgasm or not is a different matter. I personally think that it should not affect orgasm. And I also think that it should not affect the orgasm of the female. Should not. Okay, but of course we can discuss that. We can discuss that. I can share you some examples with you. So if you pass urine better at night, many of them also have got less nocturia. So this is proven that this particular alpha blocker has also reduced the risk of nocturia at night. And also I mentioned earlier, usually I don't switch patients to a different medication in the same class if I can, unless it's not working so well. And this study done in Japan, I think this company is based in Japan, right? So they find that if you're not doing well on another alpha blocker, you switch it to silodosin, it also works. Now, my last few slides will be more on non-medical therapy. Now, a lot of patients will come and see a doctor or go to the hospital. They want a pill. They want a pill to cure them. Just take one tablet, cure them. Or go for operation. One time I do the operation and cure. But actual fact, for most conditions, the pill and surgery do not actually cure them. So lifestyle modification is very important for urinary symptoms. So if you have frequency, then of course you don't drink so much before the sleep or before the journey or before you see a movie. You know, you go into the movie when you were young, you can bring one bottle of Coca-Cola and drink it and sit through the movie. But now when you have symptoms of the urinary tract, you can't do that anymore. And also you must know where the toilets. So before you board the flight from Kuching to KL, you go to the toilet first, empty the bladder first. If you're shopping in UK, my daughter tell me, Mark and Spencer will always have toilets. Okay, on KFC in UK also have toilets. If you have to sit for long hours, like going to your granddaughter's wedding, you may have to wear Pampers, or you can take the medication as required. And I know that some medications you cannot take as required, but some of the medications, like for overactive bladder, you can take it as required. Even for slow urination, you can take it as required. But if you want to shrink the prostate, if you stop the medication, the prostate will grow as well. And it's not only just the fluids. If you take sugar, take salt, then of course they will also cause a diuresis. So time voiding. My daughter is a physician in London, and she looks after a lot of old people. So many of these people actually have urinary symptoms. So it's important to give them medication if necessary, but what is even more important is bladder care. As you grow older, your bladder sensation is less. You cannot walk as fast to find a toilet. So you must practice time voiding. Empty the bladder 2 to 3 hourly, especially if you have medical conditions like stroke, diabetes, or you have a bit of dementia. The feeling is very much less. And sometimes the bladder don't empty so well, you may have to practice double voiding. Now, physical activity has been proven to improve many things in life, including urinary symptoms. And this is a study done by Korea, Japan, Taiwan. Now this come up with very good studies. You mustn't only look at just studies from the US or UK. So this study done on 70,000 Korean men, and they find that those who exercise have much less urinary symptoms. So finally, this is more or less my last few slides. So which drug would you use? For today, if the patient has slow urination, I will use an alpha blocker, example Urif. Take it for 1 or 2 weeks. If you improve, then you tell the patient, look here, this drug will not shrink your prostate is enlarged. We give a drug to shrink the prostate. If the patient says, no, doctor, I don't want to come every week to see you. Okay, money is no concern. And then my PSA is above 1.5. I do a rectal examination, I do ultrasound, prostate enlarged. You can give them dose therapy to start out with. Or when they can come back later and they say, oh, okay, now this alpha blocker is working, but no, it's a bit expensive, $2 or $3. Maybe can I buy something for less? Then you can give them a cheaper alpha blocker, but you tell them you have to titrate it upwards. Okay. Sometimes some patients, they actually have low blood pressure, heart failure. You cannot give them alpha blocker. Then you can give them just a 5-alpha reductase inhibitor, but warn them you have to take it for up to 6 months for it to show any effect. And after 6 months, if the prostate is smaller, you can reduce the dosage or you can drop off the alpha blocker. If the patient has bothersome urinary urgency frequency, you give them something for the bladder. For example, a beta-3 agonist like mirabagon. Okay, so look at your practice, look at your patients and see what you will do. Okay, so men's health, urinary symptoms is very important. And medications, exercise, dietary therapy, and of course, for men's health, you have to monitor. You have to monitor their body weight, their sugar. Body weight is very important. So if they have no choice, then to go for surgery, then to me, TRP is still the gold standard. But TRP, you require only in very, very small percentage, only 9%. Only 9% of patients. Of course, I have mentioned earlier, you have to remove the stones. Obstructive uropathy also very rare, very, very rare. Now you can see all kinds of advertisements for water therapy, microwave therapy, radiofrequency therapy, laser therapy. But I think TRP is still the gold standard. So this is my last slide, the take-home message that I think alpha blocker, for example, Urif, you can use it with maximum dose immediately without dose titration. If the prostate is enlarged, either by the PSA or by rectal examination or by ultrasound, you give a drug to shrink the prostate. If bladder is the problem or the main problem, don't give the medication for the prostate. You have to manage the patient as a whole, which I think you are doing already anyway. Don't forget about depression, constipation, insomnia, and lifestyle changes are very important. Now I got one question. This is my email address. If you want my slides, you can ask from the organizer or you can ask for me. Send me an email and I will send you the slides. So one last question. This is an MCQ. I think this is very popular nowadays in CMEs. We'll set the MCQ. This one, there's only one answer. Okay, only one answer. You can put the answer in the chat box if you like. And you can WhatsApp it. And the organizer or myself will arrange to send you a mystery prize. Let me see any question. Any question, type in the chat box. Okay. All right. I think I cannot see you. I cannot hear you, but I can only communicate with you by the chat box. But you can send a WhatsApp to us and we can reply to you personally if you like. So there's only one answer. Choose the answer and those with the correct answers will think of some way of rewarding you with a mystery prize. If you have been listening to my lecture, you should be able to give the answer, although there's some quite detailed questions. Okay, over to the chairperson. Any questions in the chat? Let me see. Crystal clear. Oh, well, quite good comments. Oh. Okay, only good comments. No real questions. So you either means my lecture is very good or my lecture is very bad.
Hi, Dr. Clarence. There are a few doctors who raised up their hands. Maybe we can ask them if they have any questions. Maybe I would like to ask Dr. Vanny.
You can unmute them, right? We still got, how much time we got? We got 10 minutes, right? You can unmute them and ask them to ask if they don't want to type or they cannot type well. They have, for whatever reason, they have we doctors, we also human beings. We have rheumatoid arthritis. We have glaucoma. We can have cataract. So sometimes they want to talk.
Yeah, I think they can unmute themselves.
They can. Oh, wonderful.
Yes.
Okay, I already got an answer for the question already. So at least one person deserves a prize. We will send you the prize.
Yeah, Dr. Clarence, there's one question. It asks, the question is, how serious is hydronephrosis and prostate enlargement relationship?
Okay, I will just let me just see. How can I go backwards? Yeah, I just go backwards. Very easy. I think that is in the slide already. So hydronephrosis is only 1%. 1%. When I was in medical school with Jara Menon, in the belly and love, you will say, my God, you don't treat them, they go hydronephrosis, they go into kidney failure. No, we frighten everybody, but it's only 1%. But that 1% you cannot miss. And it's very characteristic. They will have nocturnal aneurysms, slightly distended, slightly tender bladder, ultrasound shows bilateral hydronephrosis. So these patients you have to refer. So don't miss these patients because often if it's missed for say a year or two, then they can go into irreversible renal failure. And I tell you, we do have, even in Kuching, in our dialysis unit, we have one patient who is like that. In other words, the patient or the doctor or whoever or the system have missed his obstructive uropathy and now he's gone to dialysis. And this patient on dialysis, because they have obstructive uropathy, they can produce a lot of urine, but the urine is just dilute urine. Okay, so it is a serious problem, but not common, not common. Not common. Okay. So we got two answers which are correct. We got two answers which are correct to the question. Okay. So maybe I just go through the question and then I just elaborate on the question and then we can pass on to the next. So BPH is progressive to bilateral hydronephrosis in majority of patients. The answer is no. Answer is only 1% with hydronephrosis. 30% of them will get better. 30% get better. So in other words, they take the Tongkat Ali, the Jamu, all that, they get better. They swear to you, doctor, I take this soap palmetto, I take this ginseng, I'm better. Okay, but I'm not saying they have no effect, but they can get better by itself. And 30% of them will progress, and 30% of them will let me just go back to the slide. So this is the natural history. You must know the natural history of a disease. Okay, it's like a flu. A patient got flu, come and see you. Okay, the patient see you, you give them blah blah blah. You don't disturb antibiotic. When they reach the last doctor in 5 days time, that doctor give them a course of antibiotic. He get cured. Antibiotic cure me, but actually no, they are determined. The viral flu is programmed to improve. Okay, so we have to pick up this 16%. We have to pick up this 16% of patients who will deteriorate so that you can treat them. Okay, these are the risk factors which you must treat. Usually these are people who are very poor flow rate, patients who have got enlarged prostate. These are the group that you need to treat them aggressively early so that they can avert surgery. Alpha blockers take 6 months to work. No, that's just the reverse, right? 6 months is the 5-alpha reductase inhibitors. Alpha blockers take only hours to work. Some take longer. Silodosin works very fast, within hours. Reduced ejaculation is the most common side effect. You have to know this, and sometimes you may have to tell the patient. Because the patient will others call you at 2 o'clock in the morning. Doctor, what happened? Your medicine you give me, no, my girlfriend not happy, blah blah blah. So that is the complex answer is C. So those who send the answer C, you get a prize. The PSA more than 1.5. If the PSA is less than 1.5, don't give them the expensive medication to shrink the prostate gland. And again, not all the enlarged prostates require medication. Many patients will go to a health screening, so-called wellness. Wellness means wellness of the hospital, wellness center, and get ultrasound, and then they say, oh, my prostate is enlarged, please give a medicine to shrink it. And then after a few months, they look at the side effect, they say, my God, I have been very badly treated by my doctors. Okay, let me look at the chart again, and otherwise we will call it a day for my section. We move on to okay.
Dr. Clarence, there's another question. Question about PSA from 3.29 to now 9.58. If it is increasing over 5 years, does he need a biopsy? He has a LUTS urine examination and clinically no hematuria.
Okay, wonderful. Actually, I see 3 questions. I answer the easy one first. First, how long do you usually use the alpha blocker? Alpha blocker, I will give them for as long as they require it. Usually for about 6 months. If the prostate is big, you take 6 months for the 5-hour reductase to work. So according to scientific studies, you give them dual medication 6 months. After 6 months, you can stop the alpha blocker and see what happens. If the symptoms recur, then they can take back the alpha blocker. They can also take the alpha blocker on don't tell the drug company this. You can take it intermittently. Okay. So if they're going for holiday, they take the alpha blocker. You go and play golf, they don't want to stop halfway and go to toilet. They want to play golf all the way 18 holes, they take the alpha blocker. So they can actually stop the alpha blocker. And also very important, if they get unwell, they got a heart attack, they better stop the alpha blocker, because if the pressure is already low and the caretaker or the nurse comes and still give them all the medicines, so you can stop the alpha blocker. I'm 87. Wow, wonderful. 87, wonderful. I hope I can work to 87 as well. 87 on URIF BD I have to get 3 times a night to pass urine. Any comments? Okay. So many drugs will come and say that you have to take this drug according to this instruction. Okay, so URIF is taken twice a day, but there are studies which shows that you can take it once a day. So typically my patients, especially older patients, I take it once a day. And also Asians will be smaller. So, and some of the drugs, some of the alpha blockers, I ask them to take it every other day. So twice a day, I think maybe a slightly overkill, unless you are very big size. And that should reduce the nocturia. If it doesn't, then you have to try other strategies. If the nocturia of 3 times disturbs you, you have to try other strategies. And actually I have another lecture on nocturia, how to reduce nocturia. Again, it's the same concept that I have. You have to go by medication, lifestyle, fluid therapy, dietary therapy, and bladder care. All these must come in together to treat any condition to me, like especially a condition like nocturia. Okay, finally, the last question about PSA. Now, PSA is not part of the talk. This talk is on BPH. The PSA is a difficult one. PSA normal is 4. Okay, anything more than 4, the standard recommendation is to do a prostate biopsy, because we don't want to miss a prostate cancer. But the consent for prostate biopsy is an informed consent. In other words, prostate biopsy can kill the patient. It can cause infection. It can cause bleeding. On top of that, once you biopsy, you may miss the cancer. And then, if you found the cancer, if the cancer is of a very low grade, the patient do not require treatment, but it causes a lot of stress to the patient. So that's why the Americans have actually taken off PSA screening for prostate cancer, unless they meet certain criteria like family history, symptoms. So PSA from 3.29 to 9.58, if the patient do not have obvious evidence of infection, would be indication that he may have an underlying cancer. Increasing over 5 years means the cancer is growing very slowly. Depending on the patient, and the main factor is, can the patient live another 10 years or not? Because prostate cancer is very slow growing. So if you suspect prostate cancer, like in this case, and the patient can live another 10 years, then you will require a biopsy. And of course, he is willing to go for further treatment. If you do the biopsy and say, look, I'm not going for surgery, I'm not going for radiotherapy, there's no point doing the biopsy. Okay, I think that's about it. I think we have to stop here, because otherwise I'll be infringing on the time, this one. Okay. Thank you so much, ladies and gentlemen. I really enjoy giving the lecture. I hope you all learn something from me. Any things I've said wrongly, please WhatsApp to me or email to me, and I'm more than happy to respond, to discuss, because I think it's important we share.
Thank you, Dr. Clarence, for the very informative presentation. Thank you so much.
Okay, so
Oh, doctor, you are muted.
I'll stop my video and I'll let you all carry on with the part 2 of today's presentation.
Yeah.
Bye.